Hey everyone, it's Adam Farkas, and welcome to another ODWire.org webinar. Tonight we have a really special guest, Dr. Morris Waxler, who you may not know by name, but you certainly know his work. He's the former Food and Drug Administration official in charge of approving Lasik vision correction devices between 1996 and 2000. But over the years since Lasik's initial approval, Dr. Waxler has studied the complications due to the procedure. And he's changed his outlook on the procedure. And you may have actually seen him on CNN or MSNBC talking about his feelings about LASIK. But it's very difficult to actually understand the issues based on sound bites or just hearing him speak for 5 minutes. So tonight we have him for the full hour, and he's going to go over what he thinks LASIK, the complications are and the impact on public health. And you're going to be able to ask him questions. So again, type into the question box as you have questions, and we'll go from there. So with that said, why don't I turn the presentation on over to Dr. Waxler. Let me get your keyboard and mouse going. And I guess, Morris, take it away.
Oh, thank you, Adam. I appreciate the opportunity, and I look forward to answering your questions as they come up. Well, so what is the evidence that LASIK makes healthy eyes sick? Let's start off. Well, our summary is basically that the corneas never completely heal. They're permanently weakened, vulnerable to trauma and inflammation. LASIK causes neuropathic dry eyes, and there is progressive pathology. So let's go over each of these items. Where is that little?
There we go. I'll get it for you. Right there.
And also, LASIK devices, let me go back here a second. This is my apologies. Okay. So LASIK devices also cause keratosis, which is corneal bulging, degrades night vision, creates unstable vision and regression to the original vision condition, and creates eye care that would otherwise not be necessary. Now, first of all, LASIK, what do I mean when I say LASIK corneas never completely heal? First of all, there are permanent pathological changes. The keratocytes are reduced in number. The edge of the flap never completely heals. That's both a curse and a blessing, because sometimes the flap needs to be lifted to remove debris or to make another cut or remove tissue. So in some ways it's a blessing, but it also means that it's never really a fully healed cornea. It's never back to what it was originally. And as a consequence, there's a risk of flap dislocation that exists for years after LASIK, 12 years, 15 years, years later. Also, there is diffuse lamellar keratitis years after LASIK. And so that's something that's also there's evidence for. These are some of the references, and I believe you will be able to access these. I put them here not to go through each item by item, but and there may be additional references, but these are the ones that I've used. Here's, I believe, the second slide that contains these references. So this is not work that I've done by any chance, by any means. It's work that has been described in the literature, and it's work that has been mostly recent work. It's not work that's old literature in the 1990s. It's work in the 2006, 2007, 2008, 2010, So this is relatively new information. And it's about all sorts of lasers. It's not attributing anything to any particular laser. Now, diffuse, this is an example of diffuse lamellar keratitis 12 years after Lasik, just to give you one example. And the opposite point, I think, needs to be made. That is, as far as I'm aware, there is no evidence that Lasik cornea is completely healed. And I think that perhaps is understandable and perhaps doesn't need to be said. But I think there's a tendency to imply that somehow you have a relatively normal cornea after you've had Lasik, and then it's just simply not true. So look back. No, Lasik permanently weakens the cornea. Schmack and his colleagues, including Dr. Waring, know that we know that the Lasik cornea is weaker. There's been a number of studies, and this is one in particular. They produce a stromal scar that's very weak, and according to these authors, averaging about 2.4% of normal. And this does not really change, at least out to 6.5 years. So there's a lot of evidence that these changes that are produced remain. One of the most impressive data is having to do with dry eyes. The dry eyes produced by Lasik are due to cutting nerves in the cornea. They are different from the dry eyes that are a response to other conditions such as contact lenses. They're not a surface phenomenon. They're a neuropathic dry eye. And as a consequence, the effects on a particular individual depend upon a number of variables, many of which are not really understood. Sometimes the dry eye is very severe. Sometimes it's not so severe. The next slide provides a model which is essentially, if you take a healthy corneal surface, you cut the nerves in the cornea, you decrease corneal sensitivity, you decrease blink rate, decrease tear film breakup time, and you now have an unprotected corneal surface. So the patient suffers from dry eye, irritation, and burning to varying degrees. And I think that there is some evidence that 50% of patients suffer from dry eyes for more than 6 months. It was interesting. Today I happened to be at a meeting where I was with a friend, and we just happened to chat, and she said that I had Lasik a number of years ago, and I basically have been fine. That's 10 years or more ago. And I said, well, do you have any dry eyes? And she said, yes, I do. Sometimes it's worse than others, but it's not severe enough to be problematic. And she was happy with her Lasik. So I'm not saying that everybody that gets dry eyes due to the neuropathic changes is suffering or is not willing to put up with the difficulties. But it occurs by the nature of the surgery. Regardless of which laser, which microkeratome you use, you're going to be cutting nerves.
There you go. Let me help you here.
Yeah, well, okay, thank you.
There you go.
And here are the references to long-lasting neuropathic dry eyes. And the moderate, I would say that having not had a dry eye, spectacles, I've never really had an appreciation for what a moderate level of dry eye is, and I ran across a reference that compared it to moderate angina. I've not had moderate angina either, but I know people who have had angina, and it's not a pleasant matter. So that gave me some sort of sense of what a moderate level of dry eye might be. Some other studies by Hovanesian and others have found that 6 months after LASIK, 48% experienced dry eyes, soreness to the eye 6.7%, sharp pains 8%, and a sense of the eyelid sticking to the eyeball 5.6%. An eyelid sticking to the eyeball doesn't sound like a lot of fun. So even if it's at 5.6%, that's not a good thing. And here are some other data about the rate at which dry eyes occur. This doesn't talk about the severity, so that's an issue that, as far as I'm aware, has not been adequately studied. But at 6 months, manufacturers reported to FDA that 21% experienced dry eyes, neuropathic dry eyes. And interestingly enough, this is confirmed by the literature I was able to read. Approximately 25% at 6 months is reported in the literature. And you can see those numbers there. The numbers vary, and this is what I've learned. And even at 5 years, 4% of LASIK patients are reported to be experiencing dry eyes. And as I said, the woman I talked to today still has dry eyes at 10 or 15 years out. So she tolerates them well, but maybe others don't. And I suspect that's true. I've talked to patients on the phone who've had LASIK, 10, 15 years ago, and they're still experiencing dry eyes. So exactly what the variables are involved in that, the depth of the cut, the area of the cut, whether it's a superior flap or a different sort of flap, what kind of microkeratome was used, I don't think we understand the variables that go into either the not the persistence so much, but the severity of the dry eyes. I don't know. Something keeps going on here. What do we have in here?
There we go.
There we go. I seem to have a little. There we go. Okay, LASIK and contact lens dry eyes. I referred to this earlier. I think the comparison that some people make between, well, you get dry eyes with contact lenses. It's a different, from my point of view, it's a different it's a different matter. The etiology is different, and also I don't have on the slide, but obviously with contact lens surface irritation dry eye, you can remove the contact lens, and you no longer have the irritant there, which is not the case with corneal neuropathy. The other matter I discovered was that there's a progressive loss of keratocytes. A long time after, 6, 7 years after, there is a progressive loss year by year, and you'll see in the next slide, I believe, a graph of that. Probably this reduces the stiffness of the cornea. That's another another indication that the cornea is sick and is not in its ordinary state. There, here's the slide. And this gives you a sense of it was a 5-year period. Over the 5-year period, which layers were decreasing, and you notice all the layers are decreasing. That is, the keratocytes in the different layers are decreasing. And I believe the next is a chart that shows you those percentages and the anterior flap and so forth and so on. So this rate per year for 5 years, whether it continues on after 5 years, I don't believe anybody knows. Or no one knows exactly the implications for this particular weakening of the cornea. But apparently it does impact the stiffness of the cornea. And here is evidence that keratocontagia is caused by LASIK. I know there's a considerable controversy and assertion by some that LASIK Keratocontasia is because someone didn't do the proper diagnosis. There was a latent hepatic patient that was not screened properly. But I think the evidence is this is a iatrogenic problem. And in any case, the issue relates in part to what the rate is. And the rate for those who are supporters and energetic about doing LASIK, they would say that the rate is, very low, 0.01 or less. And then there are others who say the rate is higher, almost 1%. I know from discussions that I've had with a variety of folks in a video I saw, which I can't seem to find, of a meeting at ASPIS some years ago, where there's a great deal of underreporting of ectasia after LASIK. And because this is a big medical legal problem if it's actually creating LASIK. And as you might expect, I've gotten a bit of feedback on that issue. Let's see what's next slide. Did I get the right slide or not? No? Well, I want to go backwards, Adam. What's going on? Sure. Oh, there we go. Okay, that was good. The other matter that everyone knows, but I say everyone, most refractive surgeons and FDA, everyone knows that the corneal surface is never going to be as good as it was before you use LASIK. It's more pancake-like, and it's often decentered, warped, chaotic, as microfolds. You really can't improve on the wonderful, smooth, continuous surface that you have when before you made it flat, releasing all the mechanical tensions that keep this fine surface all in one piece. Those tensions are released, and lots of mechanical phenomena come into place, in addition to the biological phenomena. There's a lot of biophysics there, a lot of which appears not to be understood completely. But these changes in the corneal surface cause adverse events. They cause blur, halos, glare, night vision losses, more in some folks than in others. And the circumstances of why it's more or less in others depend on a variety of technical issues that I think is only being elucidated now. The question is, are these blur, halos, glare, and night vision losses adverse? I would say they are adverse. Again, some folks would compare to the fact that this to the fact that people have blur, halos, glare, and night vision losses even with contact lenses or spectacles. True, but you can remove those and do away at least with some of those. And it is true that people have these defects even without spectacles. But the data I will show you in a little while is comparing the increase in blur, halos, glare, and night vision losses compared to their pre-op state. So these are all changes, all increases in halos, decreases in halos, glare, night vision, and blur. Now, some of these variables are some of these adverse events, blur, halo, glare, night vision losses, are due to a variety of problems that have only partially been resolved. I think that the laser beam characteristics these days are probably pretty much resolved, but I think that there may still be some issues there. At least as late as 2003, there seemed to be, in 2005, there still seemed to be some issues related to tracker matters, alignment, spatial relations. But I think more importantly, perhaps, are the large variabilities in flap thickness and the unknown tissue biomechanics and healing response. The latter two, I think, are extremely important. I think the complexities of the tissue biomechanics and the healing response are just, people are just beginning to start to understand that it's both the making of the flap and the removal of tissue, whether it's for hyperopia or whether it's for myopia, creates instability in the cornea and makes it hard to predict the outcomes. It's amazing that it's as predictable as it is, frankly, which is fortunate, I guess, for those who've had it. I've said this already, but I think there's a considerable evidence that that LASIK can only increase the aberrations. It can't make a normal cornea back into a normal cornea or a supernormal cornea, as far as I know from reading literature. If anyone knows differently, I'm sure you'll be delighted to tell me. Well, this is an example of what is typically found these days. Pre-LASIK with the spatial frequency curve, it's a modulation transfer function, and post-LASIK. So you're not going to find a curve that post-LASIK that's going to be in this region here, as far as I'm aware. Here are the 4 articles demonstrating the higher order distortions induced by LASIK, and that they are correlated with a loss of vision quality, typically contrast sensitivity or low contrast vision, low contrast visual acuity. The other place where these higher order aberrations are very important is that typically LASIK is done on both eyes, not always, but typically on both eyes. And the eyes heal separately. They're not identical to begin with, and they are not identical even though the surgery was done perhaps with the same microkeratome and the same laser. The outcomes are not going to be identical. The particular movement of the microkeratome is going to be in its micro actions slightly different. So the higher order aberrations are going to be a little bit off from each other in the 2 eyes, and so that binocular vision, according to these authors, are going to be worse because each cornea remodels itself in a specific pattern of injury. Let's see. There's some. My point here is that there's no evidence that, as far as I could tell, that LASIK decreases higher order corneal aberrations. Apparently, some wave-guided LASIK devices do not increase higher order aberrations, and apparently some wave-guided devices cause fewer halos and night vision problems than conventional LASIK devices. Continuing on that same theme, some reports are that wave-guided LASIK increases higher order aberrations. Some show that it increases it for some lasers but not for others, and other studies have shown no change in these higher order aberrations. So I think the jury's still out on whether these story with the higher order aberrations. But what it seems to be the case is that, consistent with these changes in modulation transfer functions, the loss of modulation transfer function, and the increase in higher order aberrations, is that there's contrast sensitivity loss in dim light. the contrast sensitivity losses are less than 1% at 6 months under all conditions, but that when you go under dim light conditions, I think we can go to the slide. It'll be easier to say this. If you look at the top slide, the top row, you'll notice that on the low contrast visual acuity, there's about greater than 2 diopter loss is only at 2.2% at 6 months, but a 1 to 2 diopter loss, it ranges, in the double digits. And if you look at bright light contrast sensitivity, you can see those are very low at 6 months. Dim light is higher loss at dim light, and white light without glare is approximately the same as dim light contrast sensitivity. Without glare, you'll notice that with dim light, there's still a loss of contrast sensitivity. And with glare, dim light with glare is, again, a little about the same. But here you'll notice we're still talking about the 6-month outcome, that as you make the conditions more severe, as you go from bright light with glare, without glare, to dim light with glare, you notice a considerable loss of contrast sensitivity. There's very little data at 12 months, so it's hard to speak about what's going on at 12 months. According to Valentine and others, at 7 years, 35% of post-LASIK patients are unhappy with their vision. And the number that lost 2 or more lines of visual acuity doubled. That's at 7 years. Of course, when we're talking about studies that are talking about 7-year data, it means that the LASIK was done with probably one of the earlier machines. And the issue there will be, is that the same situation with the newer machines? And we can discuss that later if you wish. Vision is unstable after LASIK, and there are a lot of measures of that. The other matter is that it regresses. That is, while the change may have been in the direction of improving visual acuity, that gain will regress over time. And I think we still don't understand why it regresses faster in some and thus slower in others. So it's an open question as to what the individual remodeling issues are, and I think those have not been solved yet. As far as I'm concerned, this remains an experimental procedure. As you can see, 8 years post-LASIK, only 39%, this is highly myopic eyes, have 20/20 and corrected. I don't have figures for lower myopic eyes out that late. And also there is a significant increase in higher order aberrations and a corresponding decrease in contrast sensitivity. Again, with the highly myopic eye, defined as -6 diopters, Shimizu said that vision deteriorated even with the wave-guided LASIK, because there are certain assertions that wave-guided LASIK will fix all problems. It does fix some problems that may create others, and it may have no impact on others, because some of the problems are inherent to all LASIK procedures, such as cutting the nerves, weakening the cornea, stiffening the cornea, creating a flap that can be easily dislodged or have keratitis infected in some fashion. The two other, or at least two other issues, because of the post-LASIK corneas have falsely low intraocular pressure readings, there is a real risk of undiagnosed glaucoma. And typically, as I understand it, the changed parameters of the cornea do not go with the patient. Maybe in more recent years that's started to be common, but I think we don't know that to be the case. The other thing is that there is a poor outcome from cataract surgery because of the shape changes and the changes in lens power calculations. And because of these various problems, LASIK patients need treatment for iatrogenic adverse events. There is a certain rate of keratoectasia, or ectasia, I should say, that is LASIK induced. And whether that is 0.1%, 0.01%, or 1%, there are patients who would never have to have a hard contact lens or have some other treatment, a transplant, or now these hardening gels that can stiffen the cornea, if they didn't have LASIK. So these are LASIK-related adverse events. I think they're underreported. They're probably higher than 2%, but the definitive word on that is it cannot be had if people are going to hide the data. And in late onset diffuse lamellar keratitis, the rate, as far as I can tell, is not known. At least it's not been reported. It may be, in fact, be rare, but it's, again, something that requires some treatment. And it may be a successful treatment, but it's, again, something that has to be done that wouldn't otherwise have to be done. It's an iatrogenic problem. And dry eyes, again, our favorite friend. It's approximately 20% worse than pre-op at 6 months, despite allegations to the contrary. Now, if that is moderate or severe or mild, no one knows. But again, I'm discouraged by the fact that data is not being reported, especially in the field. Well, clinics are not doing their job in terms of reporting adverse events to the agency or to anyone, as far as I can tell, because it impacts their medical legal problems. And night vision impairment, again, it's about 11% worse than pre-op at 6 months, despite allegations that it doesn't essentially exist after 3 months or 4 months. In fact, I think the evidence is that it exists at 12 months, about 11%. You'll see some of that data in a moment. Now, these are mean percent changes, that is pre-op versus post-op, minus post-op. These are changes from post-op. These are not excluding the pre-op. So these are, and these, refractive surgeons don't like to call these adverse events. They'd rather refer to them as they did to the agency, as something, sort of things that are reported by the patient. They would see them as complications or sort of patient reports or allegations that the patients made. But these are the data, and I went back and looked at all of the PMA data submitted by the manufacturers, And these submitted data I can show are underreported data. So if we just look at the 6 and 12 month data, that's the most interesting because 1 and 3 months, you know, that it does show that it continues to be a loss that started as a loss. So fluctuation in normal life, 15%, 24%, 22%, 32%. Redness, you know, it seems to grow, in fact, or at least as high as at 12 months as it is at 1 month. And blurry vision and gritty feeling. It goes down and down and down. I mean, light sensitivity is a little lower at 12 months, but seems to be coming down, but it's still high. FDA's, when I was the agency, we set a adverse event rate acceptable limit at 1%, and that's how these devices were approved, with the assertion that the adverse event rate was 1%. That can only happen if you do not call these problems adverse, and that's exactly what happened. Dryness is not an adverse event, 20%, 5% at 12 months. Halos, double vision, is that an adverse event? Burning sensation, these are changes from baseline. These are changes from pre-op. And the interesting thing about this, well, I'll go on with the slides here. It occurs at greater than 1% after safety criteria, persists for 12 months, except for these two items, these two adverse events, foreign body sensation and pain. They do decrease. The published data confirm that the adverse event rate for these problems is much greater than 1%. These are 6 months after basic. 48%, we saw this earlier, 48% express soreness, 6%, 48% have dry eye, 6.7% of them experience soreness, 8% experience sharp pain. Excuse me, I have to have a drink of water, my lips are sticking again. That's better. And so forth. According to Bellamau and his colleagues, Lasik dry eyes occurs in 46% of those using mechanical microkeratome, with only 9% with the femtosecond laser flap technique. But notice, 9% is 9 times the 1% safety criteria. The data of Pava and his colleagues show that Lasik-induced incidence of dry eyes at 6 months is 9.5%, with nasal ranges, and 35.3% in eyes with superior ranges. So this is one of the factors that's understood. But again, even the lower rate is 12.5% higher than the safety criteria. So, in fact, I have not been able to find an example. I do not believe. Well, there is one example, perhaps, where no adverse events are reported from Lasik. And, we were not talking strictly about this, but they say no adverse events. It's hard to believe that in the light of these other data, but that's just an opinion. So the adverse event rates at 6 months, published data versus data reported to the FDA. The published data shows that the adverse event rate is always higher published than it is that was reported to FDA. And that's been pretty consistent. Again, even when it's the FDA data, even though that data is underreported, and I have some other internal checks from the FDA data that shows how much that was underreported. And these rates all exceed the 1% by quite a bit, you'll notice. And they persist for at least 6 months, most of them for 12 months. Here are the citations for adverse events that we just talked about, and you'll have them all available to you. I just wanted to make sure that I included the citations so you didn't think I was just sort of blowing smoke. Now, this is interesting. Manufacturers, and unfortunately my dear friends at the agency, have claimed that dry eyes, night driving difficulties, and similar problems are rare or nearly non-existent. I'll show you the graph that they have. And the original site for this graph is at agni.net. And FDA has used this graph in its website, which I have raised that question with them repeatedly over the last year, and it remains on their website. There is no data that supports this graph, and I'll show you the data that actually comes from FDA report. And the other issue is the high satisfaction rates, implying that double-digit rates are incorrect. And I'll show you why I believe this. Let me say that again. The high satisfaction rates reported for Lasik, that is of 95.4%, imply that reports of double-digit rates of dry eyes, night driving, and similar problems are incorrect. We'll go back to that in a moment. Here's the graph that is published on the web and by FDA. This graph, as far as I know, there's no data for the implication that hernia inspectionists end at three days. Sensitivity to light ends at 1 week. This is not true. Hazy or blurred vision ends at 1 week. Dry eyes, as we've seen, goes out for forever as far as we can tell. Glare, difficulty in night, fluctuations in vision. You can see the data. There's no data behind it. I've asked the agency to provide the data behind their publishing this graph. As far as I know, the agency did not produce this graph, but took it from a refractive surgery clinic that was a site for a particular manufacturer's, one of their consultants. So I would love to know the source of this data because I cannot find any. Let's go to high satisfaction rates. Now, there are a couple of issues with these high satisfaction rates. And as having been trained initially in my youth, which was a long, long time ago, in both psychometrics and psychology and neuroscience, I know a little bit about scales and how they're used and how they can be confusing. The way in which these satisfaction scales, these quality of vision studies are done, is admirable in some sense. I think the best of these studies do provide perhaps a better measure of some of these complaints of dry eyes and other problems, night vision problems. But they have other problems with them. And as far as I know, none of the studies use controls to deal with this. The first one is something you may or may not be have the language for. One is called cognitive dissonance. Essentially what this means, to make it in the vernacular, is I bought something really expensive, and this has got to work out. This is very important. These are my eyes, and I just spent $4,000 to have them fixed. They better be right. So I'm going to ignore in answering these little scales. I'm going to have a bias towards saying that these are better than they really are. The other issue is that, as far as I know, has not been taken care of in all these measurements, is a halo effect. And I mean the halo effect, not that they have halos, but the halo effect that comes from the white coats of the surgeons. These are people who are trusted by their patients. And typically, as far as I know, these measures taken in the clinic with the clinic staff that makes every effort to be as trusting and wonderful and warm as possible. The other is the time and the place of the measurements. Usually it's not mentioned that when these were taken. If they were taken 2 days after, they're taken 3 weeks after, 6 months after, 7 weeks after. So time and place of measurement is important. When I say these high satisfaction rates are consistent with reports of persistent double-digit rates for eyes and similar problems, you might say, what is he talking about? Because the rate of satisfaction is, what did I say, 95.4%, and I just said that, well, the adverse event rate is something like 15, 20, 10, 11. So they seem to be a mismatch. What I think is going on here, perhaps, and that I don't know, it's a hypothesis of mine, but it's based on the data I presented you. Here's my point, is that satisfaction rates are 95.4%. And let's assume that they are a surrogate measure of LASIK success. So it means that the dissatisfaction rate is 4.6% as a surrogate measure of LASIK failure. Therefore, it is a surrogate measure of overall adverse event. Here's my hypothesis. I believe that the published in FDA adverse events of approximately 20% are correct. However, it covers the entire range of severities. My guess is that these quality of life measures, because of cognitive dissonance and halo effects and time and place, are estimating the total dissatisfaction rate, so that the LASIK failure rate is higher than. But here, even with a 5.4% failure rate, it's higher than FDA's 1% criterion. So even if you take the lowest number that we have that we can rely on, that is obtained from these quality of life measures, you still have a 5.4% failure rate. Now I understand that the possibility exists that this 5.4% is the higher bound in some people's estimation. That is, it includes all the severity. The highest severity is 5.4%. But that goes in the face of the data from both the published literature and from the literature, the data sent to FDA, that the adverse event rate for these problems is somewhere up around 15 or 20%. It may be that this 14.6% difference are the less severe failures. Someone should do a study to assess that. I think this is my last slide. I would emphasize that the high and persistent adverse event rates are due to permanently damaged corneas, neurotrophic dry eye and itching eyes, loss of low contrast sensitivity, induced corneal distortions, and induced corneal stability, with an end case in some of keratoplasia. But this corneal instability could result in a variety of problems. Thank you, and I look forward to dealing with your questions.
Great. Well, thank you, Morris. I think I can safely say that you have opened up a major can of worms if the response to your lecture is accurate. We got a whole bunch of questions here, and I'll try to actually ask them to you in the order in which they were given to me.
Okay.
But importantly, I just want to let everyone know that a PDF of these slides will be available on ODWire for you to download, because I know a lot of folks have been asking, can I actually get the slides with the citations? So those will be available when the archive of the webinar goes up on the site within the next couple of days. fear not, you don't have to actually pore over the archive to find the citations. You'll have the PDF. So I guess let me just go back to the beginning. You know, I think that you can appreciate that this is a fairly controversial topic. And so people have all kinds of questions ranging from very basic questions to much more detailed. So I'm just going to try to hit these chronologically as they came in. So here we go. Can you define what you mean by a cornea that is completely healed? You say that after LASIK, cornea is never completely healed. What does that actually mean?
A completely healed cornea, that's a good question. A completely healed cornea would be a cornea where the flap is seated in a anatomically relevant position, and the edges of the flap are healed around, and so that it's solid and cannot be jarred loose, that it hasn't altered the structural integrity of the tension bands that exist around the globe of the eye, that the center of the area where the divot or the trench was removed is somehow remodeled, regrown into a in quotes non-pathological state, that the keratocytes are not continuing to be lost over 5 years. So I think I haven't really thought about what's defining a normal cornea, but clearly this is a pathological cornea after LASIK, and it's a cornea that is weaker. It's a cornea that has instability introduced into it. It is a cornea that has, well, measurements of intraocular pressure cannot be made because it's, you know, the altered surfaces under the cornea as well as inside the cornea as well as at the surface. So I think a normal cornea would be a cornea that has not been glazed, has not been having like a keratome onto it.
Right. Okay. Next question. You spoke about the loss of keratocytes in the post-LASIK cornea. With the studies that you actually cited, can you compare the baseline loss of the keratocytes just due to aging alone versus what you see post-LASIK? Because it seems to me without that baseline, just with aging, it's really hard to actually say how significant the loss is.
Let me go back to that. No, that's not it. There we go. Again, these are not my words. These are the author's words. But I would say that, let's see, it's just, this is at 0 time. This is a normal, where my arrow is up here at the top.
Right.
These are the pre-op values. That's at time 0 before. So these are the starting points. So when they're talking about a decrease, that's the decrease they're talking about. Again, according to these authors, if I assume that I understand them correctly, and you're welcome to read these articles and write to me and we can chat about that. That these are, again, these are rates per year. This means that every year there's a 4.3% decrease in the keratocytes in the stromal layer and so forth, but 8.4% in this region, and so forth and so on. That is per year, the rate of change per year. So, and it was still going on in 5 years, so the question is a good one, and I don't have an answer for it, to be honest with you.
So that's something I guess that we could all look up after this is done. A lot of questions here dealing with PRK versus LASIK, and what are your feelings about PRK versus LASIK?
I have not reviewed the literature on PRK. I've seen some of it in my intensive review of LASIK, but I have not, honestly cannot speak data on PRK. I just haven't made those comparisons, and I probably won't. This was too much work.
Right. So another interesting question here. So you quoted a whole plethora of studies. A lot of them had patients that were sort of from the beginnings of LASIK or very early on. How many of those patients actually had pre-op contraindications for the procedure, got it anyway, and obviously had a bad outcome? And is that skewing the data versus taking a population of patients that have been appropriately screened with known contraindications who didn't have the procedure done?
I don't know if that data exists. At least I didn't find it. That would be a very good study. Of course, the question in my mind these days is would that be ethical to do the study given what we know? And that's another question, another issue we can discuss. I mean, is it ethical to produce these kind of problems in a normally sighted eye, knowing that you're going to have these progressive losses, you're going to have these strength problems, you're going to have, even if you have an outcome which the woman I spoke to today, she had a great outcome 10, 15 years ago, and she has a little dry, but I don't know what her eyes are going to be like, and she's still a young woman. She's in her early 60s. I think that's very young. And so what is her eye going to be like? And is she going to get ectasia next year or 5 years from now? I don't think anybody really knows the answer to that.
Right.
What is that stability going to produce?
Right, and so you don't know of any studies where they very carefully controlled and tossed out any patient who had known contraindications and just denied them the procedure flat out to see what the complication rate is. And there's no studies like that.
I'm sure that data exists within clinics because as you might imagine, I've heard from my former refractive surgery friends a lot. And they certainly assert that they have lots of data that shows that they don't treat patients that have these risk factors. In fact, they're getting better at excluding keratoconus at risk patients. I don't know. I've not seen that data. They don't release that data. So I have no idea whether that is in fact the case or not. I just can review the published literature. So that I really can't speak to. And I don't know of any published data, and I don't believe we ever saw those data in the FDA trials. The other thing you should understand about these trials run by the companies, these essentially are best case studies. About that, these are best case studies. Even if they reported everything, we had criteria for exclusions for people who were risky. So it meant that there were no risky patients in these studies. So this was the best they could do. When you look at that data and the report of adverse event rates of 15, 20, 25% at 6 months, 12 months, that's really worrisome in this select group of patients.
Right. Here's an interesting question. Do you happen to know how many complaints have actually been lodged with the FDA from patients that have had complications?
I'm sorry, say again?
Do you know how many patients have actually lodged complaints with the FDA over complications that they've had?
Well, before a few years ago, I think there were a relatively small number, maybe 200. I think now the number is up maybe in a couple thousand. I don't track that, so I don't really know. And that database is so strange. We can get into that sometime if you want to, but it's a very odd system and not terribly reliable. So I don't even look on that as data. Some I know, some anti-LASIK patients are really focused on looking at that data, and at FDA, at one meeting, I know that they said, emphasized it because it had very few reports. I know patients who've had terrible outcomes and have not reported it. And I tell them where they can report it, and they don't report it. They fairly discuss it with themselves for having gotten paid for something to injure their eyes, and they just say, I'm not, they don't see any reason why FDA is going to do anything, and they may be right there. So knowing that the report could come in. So if you're looking at those MedWatch reports are much, much lower than you would anticipate if we had a real 20% adverse event rate in these halos and other problems. So the fact that surgeons and manufacturers can feel comforted by that, I'm not so comforted, because the independently published data on it show these high rates. The data from the manufacturers that they submitted to the FDA shows these high rates. The fact that people have these rates, have these problems, and put up with them is a social phenomenon, I think, and more than a medical problem.
Great. So here's an interesting question, actually. So philosophically, don't contact lenses also cause the same sorts of adverse events? And shouldn't any study actually be asking, are patients okay with these adverse events, given that they now don't have to use glasses or contact lenses?
I think that's reasonable. I think that that's a good question. I think the thing that bothers me about this issue of comparing to contact lenses is that contact lenses are, you can remove them. If you don't like the outcome, you can remove them. You can't do anything about LASIK. It is done. You get LASIK and you have it. You can't. There's nothing to remove. For some of these problems, there's really no treatment. Yeah, you can do it again, which evidence shows that actually you're probably increasing the risk of all these problems. So that's my big issue with regard to comparing to contact lenses. It's just not. It's not a reasonable comparison given the nature of the treatment.
Right. So here's another question. Aren't most of the studies that you cited dated and confirmed that using the microkeratome really wasn't the best option? So you made an allusion before to wavefront technology. Isn't it true that the advances in technology really have reduced the incidence of complications?
I don't think so. I don't think so. Because first of all, from my data, that not my data, the data that I gleaned from the FDA website includes all LASIK devices that were approved, those with the most recent to the earliest of LASIK tests. So it includes the full range, and I didn't see any major difference in the high rate of these problems. They're there regardless of which laser, regardless of which microkeratome. You can be worse with some than with others, but none of them are good. I mean, the rates are still 10, 15, 20%. And that's true of published data, and that's true of the data from the FDA's material.
Right. So, question here. So this is a sort of an interesting one. Do you know of any data that LASIK increasing the incidence of retinal detachment?
I haven't looked at that in great detail. I have looked at it a little bit. I suspect there is. I know that I'm pretty sure that in some vulnerable eyes. That is probably the case, but I did not review that particular literature. I had my hands full with just looking at the corneal implications.
Right. Question here, sort of a little bit far field of the webinar itself. So this is related to the petition that you filed with the FDA, and someone was, sort of asking, when did you do this and why, and what's the status of that petition?
Well, I believe I submitted it on January the 6th or something, early January this year. And I submitted it because my early attempts to talk to my former colleagues at the agency was not leading with any outcome that was useful in terms of getting them to make some changes in the website, make their website more accurate. Now, they have since then made some changes and improved the website in terms of giving more informed consent to patients, prospective patients. But they still have that infamous, from my point of view, infamous figure in there, which they have not responded to for many, many months. And I have not heard anything from the agency about regard to the petition. They have 6 months in which to respond. I would have been heartened if they had made an interim response, at least with regard to removing that offending figure, or responding at least saying where the data came to make that figure. And I've heard absolutely nothing from them. So the lack of a response to that is very unexpected. I would have thought at least they would have done something, even if they didn't respond to me. I didn't really expect a personal response. A petition is a very formal thing. They have a designated time was to respond, and the request to call these Lasik devices because of misinformation and lying to the agency is a big deal for the agency. So that's not something they would do very readily. So that would take some time. But the issue with regard to the public health alert, the agency issues public health alerts all the time. Look at some of the public health alerts for the various products that the agency lists. In my petition, I list a few of them. And they do it all the time. And why they've chosen not to at least say something with regard to a public health advisory, it puzzles me. It worries me, actually. But that's where it is.
Right. Follow-up question. You were at the FDA from 1996 to 2000. You were there sort of at the beginning of all this. How did your thinking evolve on LASIK, sort of going from pro and saying that this is something that should be available to, having real reservations about it? How long did that take you to sort of change your opinion?
Well, one minor correction, I was actually at the agency for 26 years, but the last 10 years I was in the ophthalmic division, performing various functions, and then I became the branch chief in charge of LASIK and other devices in 1996. So with that little minor correction, what we were confronted with in the early 90s, I think the early applications came in when I was still over in the science group at FDA. And the applications for the two first manufacturers came into the agency in, I think, 89, 90, maybe a little bit before that. Visex and Summit were the two competing companies. And these were applications for PRK. While these applications were being reviewed in a very stressed division and part of the agency. Unbeknownst to FDA, I guess unbeknownst, I wasn't in that division at that early days. Some refractive surgeons were making their own Lasik devices, their own lasers. And there were some that were re-importing lasers that Summit or Vitex had exported as investigational lasers because these were unlocked. They didn't have any limits on them. So they were illegally re-importing these experimental lasers into the United States. And then there were another group of refractive surgeons that were conducting clinical trials without FDA approval using these lasers, the lasers that were being understudied for these two companies for treating lasers. So this was the problem that we confronted, and officially confronted, probably starting in 1992, most of 93, with the black box, the so-called homemade lasers, black boxes, and the gray boxes. So my first task that I was given was to get these products under control because they were undermining the whole regulatory process. These were devices that we didn't know much about, and they weren't following the law. So the question was how to get them under control. And so we devised a means of doing that. Oops, I just dropped the visual. What happened? You still there?
Yep, we're still here. We still have the audio, and that's what counts.
Now you're back. Anyhow, I was looking at faces. Anyhow, now what was I? Oh, we developed a strategy. I met. This started before I was branch chief. We met practically every week for 6 months with the head of what is called general counsel at FDA up in the commissioner's office, and we didn't meet in the commissioner's office. We met with the chief counsel and his staff. We met with the director of CDRH and Center for Devices and Radiological Health and his deputies, and the deputy and the director of the Office of Device Evaluation, who was my boss, one of my bosses. I had many bosses. And so we devised a strategy to squeeze the life out of the black box owners and to squeeze the gray box owners in a couple of different ways. We issued a letter essentially saying that we would give a sort of, not amnesty exactly, but a sort of an amnesty to those who were in violation of the law if they submitted certain documents, submitted investigational device exemption documents to us, and that by a certain date. So, and the other thing we did simultaneously was that we, including myself, went out on field inspections of suspect clinics to essentially fire a warning shot over the bow. We didn't have the resources to go out and sue everybody or seize machines, but we told them we would, and we did seize a few machines. And then we brought some machines under control by bringing them in under the investigation device exemption, and then acquiring that they submit these applications. So we were struggling to get these legal products under control, to make sure we understood the outcomes. At the same time, we were trying to figure out how to get data from the two, the Summit and Vitex machines that were approved for PRK, how to get those devices approved for Lasik, since neither of the companies wanted to conduct clinical trials on LASIK. They had I think their view at that time was that we have our devices approved for PRK, and surgeons want to use it for LASIK. That's their problem. That it's not. Our manufacturers didn't want to. The manufacturers of the lasers didn't want to have anything to do with the responsibility for combining their device with a product that they didn't make. And there was a strict argument for that. However, we pressed the issue with the refractive surgery community. Myself, I was asked to go down and tell Dr. Waring and others that he was head of Damascus at that time, that they needed to bring their clinical studies they were doing on LASIK under IDEs. Otherwise, we would have shut these studies down. And so we came to an agreement with them that they would collect data, and this was mostly with Dr. Casegear and Dr. Kazarian, that if they would collect acceptable data on LASIK from a large number of sites, that we would work with them and with the manufacturers to transfer that data to the ownership of manufacturers, so that the manufacturers could then use that data in applications for LASIK. So that's sort of what we were struggling with. At the same time, we were trying to make reasonable decisions about safety and infections. So that's sort of the context in which we were working. As far as my own view of things were at the time, how it evolved, I felt very satisfied with all that. I figured that we got the lasers under control. We had, as far as I could tell, good data on the outcomes, and there I depended on the ophthalmologists and consensus amongst the panels on various kind of data issues. And I was perfectly fine. I left and went to work for Hogan Hartman, where I was recruited, and worked on other kind of products totally unrelated to the eye. And have been doing so up until about, well, I'm still doing that company, but in the last 4 years, patients, injured patients have found me and started peppering me with questions of why they had this problem, why they had that problem. I reluctantly started to look back at what's going on, and that's what brought me to the state. So my evolution really is a relatively recent time. I was perfectly fine with leaving this issue alone, and I thought we had done a good job. I think we did perhaps as good a job as we could. I don't believe, as you'll see in my petition, that the manufacturers of the refractive surgery were above board in terms of their submissions. And I provide that evidence in the petition one way or another.
Okay. Well, I think we are just about out of time, actually. There are still a bunch more questions that we haven't had time to answer, but you can ask the questions again, and we'll post them on ODWire in the webinar thread where the webinar will be posted. The archive of this event will actually be up in the next couple of days. And just as an aside to anyone, we've gotten several questions about, well, I'd like to hear the other side of the issue. And as everyone knows, our site is all about education. So if there are speakers who have a different opinion about LASIK or about anything really, we're happy to actually invite them in to do a webinar. So all you have to do is go to the site and contact us, because what we're all about is open communication. So I guess we have about 2 minutes left. Do you have any sort of parting words of advice for the folks who attended tonight?
Well, thank you very much, and certainly I would entertain any questions. Please, I think that I always want to be educated, and this is an important issue. 17 million people, eyes, I'm not sure how they count that, have been treated with LASIK, so it's important that we do the right thing for prospective patients. There'll be another 700 1,000 this coming year. Is that reasonable? Are they getting the proper informed consent? I've read informed consent documents, and most of them are pretty pitiful, frankly. You know, if I were receiving that sort of informed consent, I would be wowed with the procedure because there's no context for the problem, and the people are being all the things are just wonderful, and I don't believe they are. So there need to be some changes, and I'm hopeful that someone will, some group or somebody will be straightforward and discuss these changes and make the changes that are rational and reasonable.
Great. Okay, well, thank you so much for coming tonight. I think we all learned a lot, and I guess we will all pick up this conversation back on the site. So I guess we'll see everyone online.
But thanks a lot, Adam.
Thanks a lot.